Thanks, Karen. Morning, everybody. This talk is going to set the stage, as it were, for the rest of the talks today. I'm just going to go through basics of Fontan procedure, as Karen said, when, who, where, and why. Most of what I'm going to say, if it doesn't make sense, Karen has made a nice glossary of terms. We medical doctors are pretty guilty of assuming that people know what we're talking about. Some of them can be gobbledygook. So feel free to refer to this glossary, which tells you in layman terms what we're talking about. History is important. Brief history of Fontan. It was initially described by Fontan from Bordeaux in 1971 as a surgical repair of tricuspid atresia, as a treatment for tricuspid atresia. So everybody started calling this as a Fontan procedure. But history is cruel. Is it true? Actually, it's another surgeon from South America who described it pretty much the same time in an international meeting for the same condition. So Fontan takes all the glory. Nobody knows about Choussat. Well, that's life for you. So this was the original Fontan repair. He did this surgery for tricuspid atresia in adults, patients aged above 15 years. And he conceptualized that he can use the thick right atrium in children or patients with tricuspid atresia where the right atrium's got thick muscles that can use as a pump to pump blood from the right atrium to the pulmonary artery. So he conceptualized that you need to have two valves interposed, one at the level of the inferior vena cava, or the vein draining the lower part of the body, to the right atrium. So put a valve in there so the blood does not go back into the IVC, and another valve from the right atrium to the left pulmonary artery, so blood only goes to the pulmonary artery and does not come back. And also what he did was he followed what was called a classic Glenn anastomosis, where the SVC is transected and the right pulmonary artery, which gives blood to the right lung, is connected as an end-to-end anastomosis. So that was his concept. So in the glorious tradition of cardiac surgery, he went to the lab and this thought, can he do that in animals? Will it work? So he did that in animal models, and technically he could do it, but unfortunately none of them survived for more than a few hours. And you would think that'll be the end of the operation. No. He went ahead and did that on 3 live patients, of which 2 survived and 1 didn't. And his reasoning for that, which is still true, is he did that in normal dog or normal canine heart, and the problem he thought was that the normal right atrium was not thick enough to act as a pump to pump the blood from the atrium to the pulmonary artery, while he thought in patients who had tricuspid atresia, because the right atrium is so thick, it can act as a pump to pump blood to the pulmonary arteries. An early observation following Fontan surgery, this was observed in 1970s, and it's pretty much true even today. You don't need a homograft valve between the right atrium and pulmonary artery. You develop an inferior vena cava syndrome or a failing Fontan syndrome where there's enlargement of the liver. They can have blood through the stools and they might not pass urine. And you need large volume to maintain hemodynamics, which we still do. And maintaining slight tachycardia helps in the hemodynamics by maintaining cardiac output, and spontaneous ventilation helps as positive pressure ventilation stops the blood from coming back to the lungs, and all these patients develop bilateral pleural effusion, which is the bane of Fontan surgery even today. So whom do you do it for? You do it for children who've got a single ventricle, or they don't have the 2 hearts as the logo says. So the common ones are children who lack an inlet valve, the valve which lets the blood go from the atrium to the ventricle, like a mitral atresia, or lack of left-sided valve, or the tricuspid atresia, which was the original condition for which the Fontan was designed. Or you do it for children who do not have a good pumping chamber. Either they have a small or ineffective right pumping chamber, hypoplastic right heart syndrome, or small or ineffective left pumping chamber, the hypoplastic left heart syndrome. And increasingly now for a subset of children who have complex heart condition where we can't make them work as 2 ventricles, we design pathways in such a way that they effectively have 1 ventricle and act as a single ventricular pathway. So these are the children, and the way we describe it is Fontan is a big river, and you have lots of tributaries, and each tributaries are directed and channeled in such a way that they all enter the river. So they can come from different places. You can have children who have unrestricted blood flow to the lungs or too much blood flow to the lungs, in which case we restrict the blood to the lungs to keep the pressures in the pulmonary artery low. Or they can have balanced blood flow, but they don't have adequate pumping chamber. Or they can have restricted blood flow, like in pulmonary atresia and tricuspid atresia, where you'll have to augment the blood flow to get them onto a stage where they can come to Fontan. So the final pathway is Fontan, but each of them can come from a completely different area to reach the Fontan. Earlier on, when Fontan was done, they had 10 commandments, which was elucidated in 1977, and the children have to be greater than 4 years of age. And because they were doing a classic Fontan where they used the right atrial pumping force to pump blood to the pulmonary artery, they had to have normal rhythm. The heart has to beat normally for the Fontan system to work. The systemic veins, or the veins which drain the blood from the rest of the body, should be normal. They should have a normal right atrial volume. If the right atrium is too big, they cannot pump blood, and you lose energy in the right atrium. And the mean pulmonary artery pressure, or the pressure in the lung artery, should be less than 15 millimeters of mercury. And the resistance of the pulmonary vascular bed, or the capillaries in the lungs, has to be low, less than 4 Woods unit. That's a technical number, just it has to be low. And the pulmonary artery to the aorta ratio should be greater than 0.75, or the size of the pulmonary artery should be big enough for the Fontan to work, and the left ventricle or the common ventricle, which is pumping blood, should be good, and you should have a competent mitral valve, or the systemic AV valve, or the valve which controls blood going from the atrial chamber to the ventricle, should be functional, and there should be an absence of distortion of the pulmonary artery, or there should not be any kink or bends in the pulmonary artery. Now, we found that of the 10 commandments, the really 3 important ones, or the new commandments, are that the pulmonary vascular resistance should be low, and the pulmonary artery should be of good size, because the Fontan does not make the pulmonary artery grow, or that's what we think, and there should not be severe dysfunction of the ventricle function should be good. You can't have a poor functioning ventricle. So that was the early Fontan operation as described by Fontan himself. So you had a classic lens, so all the blood from the upper part of the body went preferentially to the right lung, all the blood from the lower part of the body went preferentially to the left lung. As everything else in medicine, we have to make progress, we have to tinker around. What someone else does is not good enough, we can make it better. So we've gone through various iterations of Fontan surgery. So the initial modification was, you don't need 2 valves, you just need 1 valve between the right atrium and the pulmonary artery. So no more 2 homographs in the IVC. And then in 1988, Marc Delaval found out that you actually are losing lots of energy in the right atrium, because loss of energy in the Fontan circuit is bad news. So he devised that you don't need an atrium to do it, as long as you have a channel which streams the blood from the lower part of the body to the pulmonary artery is good enough. So we had the total KO pulmonary connection concept, where you completely get rid of the atrial component in the circulation. So that came about in 1988, or we call it the lateral tunnel Fontan. And in the 1990s, we found out that actually that's good, but that's not good enough, because we still have one wall of the lateral tunnel is the atrium, which is exposed to high pressure, so they can dilate, they can produce arrhythmias or irregular heartbeat. So we had this extra cardiac total KO pulmonary connection, where the IVC is directly connected to the lung artery through a Gore-Tex tube, bypassing the right atrium, so the atrium or the atrial tissues are not exposed to high pressure. So as of now, that is the commonest Fontan procedures that we do, unless there's a contraindication to do that. It's an extra cardiac total KO pulmonary connection. And then we found that if the pressures in the Fontan circuit are high, they can have high incidence of ascites and infusion. So one way of getting around it was doing fenestration, which essentially is a pop-off valve, where we connect the tube, the Gore-Tex tube, to the right atrium with a small 5 or 6 millimeter hole. So if the pressure in the Fontan circuit goes up, then they can survive by using this pop-off valve to maintain cardiac output. The recent newer things are a completely catheter-based Fontan completion, which is done in a few centers, but it's not taken up in a big way yet. So these are the common types of Fontan. That's there in your glossary sheet. So the early iteration was aortopulmonary connection, and then came along the lateral tunnel, and then the newest one is the total extracardiac, total cavopulmonary connections. So another picture of it, you have a special condition where you have an interrupted IVC, where you can have a near Fontan completion, where you connect it directly to the lung arteries, or called the Kawashima operation. Now in a normal circulation, you have two pumps, as shown in this figure. So you have the blue pump, which is the right ventricle, which pumps blood from the right atrium to the lungs. So the lungs get blood under some pressure or pulsatile pressure. Blood goes to the lungs, gets oxygenated, goes to the left heart, and the left ventricle pumps blood to very high pressure, which goes to the tissues, supplies nutrients and oxygen to the tissue. And there's a pressure drop in the tissue because of vascular resistance of the capillaries in the tissue. The blood becomes blue, comes to the right atrium, and then goes to the right atrium and pumps up again. So if you've seen that previous slide, in the previous picture, the right atrial pressure is lower than the left atrial pressure. The lung pressure is higher than the right atrial pressure. Now in a Fontan circulation, unfortunately, we do not have the luxury of two pumps. There's only one pump, and this pump pumps the oxygenated blood to the body, gives oxygen to the body, loses pressure, and then comes to the lung directly. There's no pump between the body tissue and the lungs, and the blood goes through the lungs and goes to the atrium. So by default, the lung pressure is higher than the atrial pressure, but the lung pressure is lower than the pressure in the tissues. So that's uniqueness of this Fontan circulation. They are exposed to chronically high venous pressure, and the flow through the Fontan circuit is dependent on the lung pressure. That's why it's important that you have a good lungs, and there's unobstructed blood flow through the lungs. Any obstruction to the lung flow will make the Fontan fail. So that's another schematic representation. I won't go too much into this detail. All that you have to take away from this is that the venous pressure in the rest of the body has to be lower than pressure in the lungs for the Fontan to work. So what are the consequences of Fontan hemodynamics? The circulation is dependent on the lung pressure. However good your ventricle is, if your pressure in the lungs are high, you're going to struggle. There's no booster pump in the right heart, so there's no pump which will pump the blood which is coming from the veins in the body to the lungs. So it's the pressure in the veins which has to push blood through the lungs. So the tissues are exposed to chronically elevated high pressures, and there's impaired lymphatic drainage because the lymphatics depend on lower venous pressure to drain all the lymph into the veins. If the pressure in the veins are high, you'll have impaired venous drainage. So next question is, when do you do it? You do it between age of 2 to 5. In Australia, the average age is about 4.5 to 5.5. The reason why we do that is because we want the lung pressures to come down to a level where they can tolerate the Fontan circulation. And you also want to do it in a staged manner so that the heart is used to this completely new way of working. So in the neonatal period, we have to achieve three things. You'll have to have control over the blood flow. You don't want too much blood flow. You don't want too little blood flow. You want just about enough blood flow. And you also want to control the pressure in the lungs. You don't want the pressure to be too high. If the pressure is high, as we said earlier, the Fontan will fail. And you should have unrestricted blood flow to the aorta. So that you cannot have resistance to the aorta. If there's resistance in the aorta, then the Fontan will fail again because you lose too much pressure in the lung, in the systemic arteries. And there should be unrestricted return of blood to the ventricle, i.e. there should not be any stenosis or obstruction to the blood flow coming from the atrium to the ventricle. So at about 4 to 9 months of age, we do the stage 2 if needed, where the superior vena cava, or the blood draining from the upper part of the body, is disconnected and connected directly to the lung arteries. It's called a modified bidirectional Glenn. This decreases the volume load of the heart and sets the heart up for the final stage, which is the total cavopulmonary connection, which we do it between age 2 and 5. So where do we do it? The best place to do it is, of course, Brisbane. There are a few other centres which try to beat us, like Melbourne and Sydney and Perth. But jokes apart, it's done in 6 centres. There is a reason why only so few centres do it. Fontan probably is the best team sport you can see. Each one of the members of the team are important. It's not just good enough if you have a fantastic surgeon. You have to have the whole thing together. You have to have the whole package. You need to have somebody who will follow them through from birth to till they come to Fontan completion and further. You need to have a team which is happy to do with it, and you need to have an ICU which is happy dealing with the Fontan Circulation. You can't treat these children as normal children. They need very unique and special treatment strategy. And we in Australia and New Zealand probably have the best outcomes in the registry that we submit to in Europe. And in some ways, we are the only ones who have the registry, so we know what we're doing compared to the rest of the world. And why do we do it? Not because we can. The reason why we do it is it's probably the most effective palliation we have for what is otherwise a fatal condition for these children. Thank you.